Because whenever when you are slightly more experienced in echocardiography, you can buy this book, which is published by the Indian Academy of Echo, which is a very sort of a comprehensive book giving all information about echo and authored by us also. So that you can see whenever you are when you are slightly more advanced or so. Coming to the revision slides, as we told you last time, that the various inanistotic regions always combine 2D and Doppler data, and this we have already told you why.
And here, sir.
Can't hear.
No sound.
Can't hear.
Can
No
you hear?
voice.
Then
Yes, sir.
our aim in every Doppler study is to give a maximum velocities, because ultimately the velocities are converted into gradients by 4 into velocity square. And if your velocity is wrong, then your whole study will become wrong. So that is why we take multiple imaging planes. We never rely on one imaging plane and see multiple imaging planes which give you the maximum velocity. Never restrict to one thing. See for any intercurrent illness. Suppose you are examining a patient who has got severe anemia, thyroid toxicosis, or any other condition, you have increased the output state, it will sort of affect your findings also. Have multiple measurements and see all the walls. See all the walls. So these are some of the basic things which we told you and you should follow in every case of study, irrespective whether you are doing a valvular lesions or not. Then this we told you the basic thing that your system is from the onset of the QRS, we told you last time. And then all echocardiography, do not jump directly to echo. Start with a clinical information, take a proper history, examination, ECG, X-ray, and then take an anatomic information, and then followed by a hemodynamic information, which will give you a more important quantitative information. So this was all told to you last time. Now, why we told you velocity is equal is important, because Doppler the velocities. And if your velocities are wrong, use the maximum velocity. And this is the reason, because the velocity are converted into gradients, always stress on getting maximum velocity. Then we also told you when you meter an image, you get a peak and a velocity time integral. So that is when you planimeter anything. So that means in all of the lesions also, you will ultimately have to planimeter it to get the maximum velocity. Because if you don't planimeter it, you can only get a peak velocity. Thus, when you trace the Doppler envelope, then you get all information as which is all mentioned here. Any problem, go on interrupting also. So now the role of echo in a valvular heart disease is there, that number one is valvular heart disease present. So that means, in other words, a diagnosis. If it is present, then what is the severity? Then is there any other valvular involvement? That is, we always say that always examine all the valves rather than sticking to one. Cardiac functions, this is important, that you will see over a period of time. Then what are the complications? We can see both a transthoracic and transesophageal. What are the effects of the valvular lesion, like a pulmonary hypertension, any complications or anything? Then requirement of intervention. What is the type? It should neither be too early, neither too late. What is the type of intervention? Whether it can be a balloon dilatation, whether it can be surgery, and then follow up. So this is the basic role of echo in a valvular heart disease, right from diagnosis, severity, multivalvular involvement or not, cardiac functions, any apparent complications, what are the effects of the valvular lesion on the other parts of the body, then what about intervention and the type. So that is the thing, basic approach, as I told you. First, we do a two-dimensional echocardiography because it gives you an anatomic information, how much is the wall thickened, whether they are calcified or not. And number two, what is the size of the chambers, any thickness, and the functional. As you will proceed in the course, you will know whatever ejection fraction is normal for a normal person may be reduced for a valvular lesions. So you get a good information by a 2D echo. Then you do a color flow mapping for a direct visualization of the blood flow, and you can guide the Doppler beam parallel to it. And Doppler is for calculation, peak gradient, mean gradient, valve area, and again I say be as parallel to the flow as possible. All the Doppler results will depend upon how parallel you are to the flow, and this is helped by a color flow mapping. In some situations, the peak gradient is important, like aortic wall and pulmonary wall, while a mean gradient, as I told you, by tracing the Doppler envelope and then calculating the wall area. So with this basic thing, now we come to this study, the aims of a in mitral stenosis, number one, confirm the presence and then a pathophysiology. Pathophysiology is important to understand the course of the disease. Now I will not go I go slowly. Now, as you know, the mitral wall opens in diastole because it allows the blood to flow from LA to LV. So because the mitral wall opens in diastole and closes in systole, so when the mitral wall opens, it allows the blood to flow from LA to LV. That flow is maintained as long as LV pressure is lower than LA pressure. So basically, flow is always from a high pressure to a low pressure. So when the wall is
Sir, your sound is breaking in the middle.
what this is a normal thing.
Sir, voice is breaking.
Sir, voice is completely breaking.
पता नहीं भाई क्यों, I don't know why it is there because I can see
Some other gadgets have been kept beside you, sir, I guess. It is near to internet.
There might be some internet speed issue.
Maybe some internet problem being a Sunday evening or so. Because when I checked it, it was all right. So, because this is only the starting of the talk, I mean, there's still a lot of slides are left or so. So, anything it is still cutting?
No,
It's
fine,
okay
sir.
right now, sir.
पता नहीं why is it okay at one time and then again. So this was, as I told you, occurs what is the normal situations. And when in mitral stenosis, there is a mechanical obstruction of the flow from left atrium to left ventricle. So when there is an obstruction, automatically the pressure in the LA will increase. For example, always I give you an example that if you are pushing a man of 50 kg, you require a certain pressure. If you are pushing a man of 90 kg, you require more pressure. So because of stenotic lesion, which is between LA to LV, the LA pressure increases. And when the LA pressure increases, So it leads to LA remodeling. Remodeling means change in size, shape, and functioning of any chamber. Any chamber. So when the LA pressure is increased, as I told you, any chamber subjected to prolonged increased pressure increases in size. So the LA increases in size and ultimately it can lead to atrial fibrillation and LA clot formation. Secondly, the pressure in the LA is converted to the pressures in the pulmonary veins and pulmonary arteries because there is no wall between pulmonary vein and the left atrial pressure. The same increased pressure is transmitted to pulmonary circulation and it leads to pulmonary artery hypertension. And a pulmonary hypertension always leads to an increased RV overload because RV has to push the blood against an increased pressure in the pulmonary artery and can lead to RVH or failure. So that is why whenever you do a echo in the case of mitral stenosis, you see for LA size, you see whether it's atrial fibrillation or not, you see for LA clot, then you see for a pulmonary artery hypertension, and then you see for the RV size also, because these are all the effects of a obstructed mitral stenosis, which leads to a prolonged pressure, and all the changes occur secondary to increased LA pressure. So this is the basic pathophysiology. Now the diagnosis. Remember, as I told you, a history, physical examination, ECG, X-ray are very significant information they give. They can also tell you, because echocardiography is the mainstay, and they will give you first information whether you are giving with a mild, moderate, or severe mitral stenosis. We don't do a cardiac catheterization nowadays in case of mitral stenosis unless it is a very elderly individual and you want the coronary arteries to be seen. Otherwise, echo is the mainstay in evaluation of a mitral stenosis. Now, this is a common for all stenotic lesions. All stenotic lesions, because this is a diseased valve, leads to thickening, fibrosis, and calcification. Because when the diseased valves are involved, ultimately they will be thickened because of a disease process, or they get fibrosed, or they get calcified. And because of this, there is a very restricted opening. Because the normal valve may open well because it's a pliable valve, but a diseased valve will have a restricted opening. And the most important finding of a stenotic lesion is a doming of the cusp. A doming like this, it appears like this, and it is with the convexity towards the distal chamber. Doming means like you have seen a dome. A dome is convex on the top or so, and it is in the convexity towards the distal chamber. So this is a common thing in all valvular stenotic lesions. For example, here you see this is a mitral wall. You see there is a doming. That means it is a convexity. So you see the tip of the leaflet is not moving. It is only the body moving, and this produces a sort of a doming, like a sort of a dome, as you see. And here you see this is looks like this. So this is like a dome. So this you see the doming is towards a distal chamber. So this is the rather than opening nor a mitral wall normally opens like this, a mitral wall. This is how this is a 2D mitral wall episode showing a posterior cusp also. Now this is the like an aortic stenosis. You see there is a doming of the aortic wall with a convexity towards the aorta. Go on seeing till you are satisfied. This is zoomed view. This is the left atrium, left ventricle, aortic wall motion. And you see this is how it looks like. This is a still image that you see the LA, LV, and the aorta, and you see. So now you see, this is a pulmonary stenosis. This is the pulmonary artery, short access view. This is the pulmonary wall, and the pulmonary wall shows a domain toward the pulmonary artery, that is the convexity is toward the pulmonary artery. So that we have shown you all walls, and the common feature was that there was a domain of the cusp with a restricted mobility, and here it is toward the pulmonary artery, and you see it is like this. You see, this is a still image, and this is the aorta, this is the pulmonary artery, this is the pulmonary wall, and it shows the domain toward the pulmonary artery, that is a convexity toward the pulmonary artery. So again, pulmonary stenosis, and you see a tricuspid stenosis, in which this is again a short axis view modified. You see the tricuspid wall, which is thickened, possibly calcified, and a restricted opening, and a convexity toward the right ventricle, you see. So you see, all we have shown you a stenosis of all the walls with a common feature of a thickening of the wall, a restricted opening of the wall, and the convexity toward the distal chamber. So this is how a stenosis looks like in all the views or so. And then as the wall narrows, the gradients increase. Gradient, as you know, is the difference of pressure between the two chambers. In a mitral stenosis, it is a difference between LA and LV. So when the valve is narrowed, more narrow, the more pressure increase in the LA. So the greater will be the pressure difference between LA and LV. So the gradients increase. So they are related to the a valve orifice area. So the summary of this 2D summary is a clinical examination, a thickening of the cusp. You can see here a doming of the cusp with a convexity toward the distal chamber, a paradoxical motion of the posterior cusp. The fusion of the posterior cusp leads to this motion towards it, restricted opening, and the chamber enlargement. For example, the LA is enlarged with this. Now I'll come back to this I was telling you. This is the mitral stenosis M mode. Now see, this is the paradoxical motion, what we call. So you see, this is the anterior leaflet, this is the posterior leaflet. Normally, the anterior and the posterior leaflet, they move opposite to each other. One goes anterior, one goes posterior. But here, because of the fusion of the cusps and the commissure, both of them moving towards each other. Now, if you are asked what is one important sign, M-mode sign of mitral stenosis, always say a paradoxical motion of the posterior cusp in relation to the anterior cusp. A decreased opening can be found in different states. An ear slope decrease can be found in different states, but a paradoxical motion of the septum of this posterior leaflet moving toward the anterior leaflet is a more specific sign of a mitral stenosis. So this is the again you see again your thickening of the cup, they are thickened. There is a restricted opening, as I told you. The doming is present with the convexity toward the left ventricle, or the paradoxical motion of the posterior cusp moving with anterior, and chamber enlargement like a left diagnosis of the summary. Etiology for your practical purposes, the most important cause is a rheumatic mitral stenosis. And then, as we show you just now, a fusion of the commissures, I'll show you, don't worry, and a multivalvular involvement, they are more in favor of a rheumatic etiology. So I'll show you just now. So you see, this is the short axis view, modified. This is the left ventricle, this is the right ventricle, and you see these are the two commissures where the leaflets are fused together. They are the commissures here, this thing. So we always write in our report that whether the commissures are fused or open, because in a balloon dilatation, they split the commissures. They split the commissures. So this is the commissure, this is the mitral wall opening, and these are the commissures, medial and lateral and medial. So, and the same thing what we showed you just now, that in the diagnosis also, that again you see all what has been shown earlier. And in a Western countries, the degenerative mitral stenosis is the most common etiology because number one, the rheumatic is very uncommon in a Western country, less than 1%. And most of these mitral stenosis, they come in an elderly age group. So what happens, you see, this is the left ventricle, left atrium, these are the leaflets, and this is the mitral annular calcification. So in a mitral annular calcification, sometimes this calcific process extends into the mitral leaflets and it can show some functional stenosis, you see. So as we show you just now, so this degenerative, as you see here, you see here, now this is the cusp in between, but these are the this is the annulus, the mitral leaf. So this calcific process is continued into the mitral leaflet, and you see the increased gradients. The mean gradient is about 7 or so, and because we have planimeter data, you can get peak, mean, and the VTI, everything. So there are many causes of mitral stenosis, but for you, remember a rheumatic and degenerative. Sometimes you may get a patient of mitral stenosis at the age of 50, 55, and you find a mitral annular calcification. And if you find these increased gradients, that means it is a mitral annular calcification leading to a stenotic lesion. So these are the two main for you. Others you can just for the time being. So then we come to the severity. Now, as I told you, so you know the pathophysiology. You know what are the 2D features of mitral stenosis. We have only discussed 2D features. You know what is the basic etiology of mitral stenosis. Now, once you, as I told you, that the role of echo in valvular heart disease is diagnosis, and next is severity. Because the thing is that is the first slide we showed you. Now, there are two ways to first we do a 2D echo. As we told you, that 2D echo always gives you a semi-quantitative idea. It may not give you 100% idea, but it will tell you whether you are dealing with a mild, moderate, or a severe mitral stenosis. And then you planimeter the mitral wall. That will show you just now. The first coming to the 2D echo only. Now you see this. Now here you see that there is a mild thickening of the anterior mitral leaflet coming toward the tip or so. So that means it is not a very, and the opening is quite good. You see the posterior leaflet is moving towards the anterior leaflet, so it is not that grossly severe because it's a very pliable wall. It shows a good movement and there's a mild thickening also. Now you see how much it is how much is the distance between the anterior and the posterior leaflet, showing a good sort of image. As coming to this, now you see here, as compared to the previous one, I'll show you again the previous one. You see, there is a good space between the anterior posterior leaflet, and you see the thickening is mild or so. But coming to this next one, you see there is a very right up to the annulus, and there's hardly any opening between the anterior and the posterior leaflet, and there's huge dilatation of the left atrium. So that means this is more of a fibrosis of the mitral leaflet as compared to a simple mitral stenosis. Third, you see a calcific. Now this is that means the severe mitral stenosis. Now remember one thing: a doming is a sign of mobility. Why? Because the leaflet tips are fused and they are thickened at the commissures. It is only the body which moves. So here you see, because of a very marked calcification, you don't see any significant doming because the mobility is markedly reduced because of this calcium coming all the way. So it is in the earlier stages you will see here. Here you can see a better doming because it is a more pliable leaflet. It is restricted at the tip and at the annulus, but the middle partial moves very well. Here you see there is a less doming. It is there, but it is less. And here you see that there is no doming, but there is a marked calcification. Now, the advantage of this is that suppose you do a Doppler study and you find that by Doppler, your diagnosis is coming as mild or moderate. That means there is something wrong in your calculations. This gives you an idea that you are dealing with a more severe mitral stenosis because it has got a calcified mitral wall. So that is a semi-quantitative idea. Then 2D planimetry. 2D planimetry means it is the most accurate method for estimation of severity. It is not affected by hemodynamics associated valvular lesions. We usually take a short axis view, and in that this will be more clear to you when a when a demonstration is given to you. You in a short axis view, you see a short axis view consists of a view at a aortic level. Then you come down, you come to a valvular level. Then you come down to a papillary muscle level. So what we do, when in a short axis view, we come down to a papillary muscle level. From the papillary muscle level, as we slightly come towards the mitral wall, you freeze it, and then you see a mitral wall, and you planimeter it. So this you can be very easily understand. Now here what you try to show, it is not for you, that you have to be at the tip of the leaflets. Now this is the more at the tip of the leaflets. So the measurement should be at leaflet tips. You can know from how do we know that we are at the tip of leaflet, because that is the shortest area which you can get. It is a zoom mode. Made a gain setting should be adequate and include commissures. When the commissures are open, for example, this commissure is open and the commissures have been included in the planimetry. So this is how you get a mitral area. Remember, again, I repeat, you'll understand it much better when a live demonstration is shown to you. But remember, it is the most accurate method, not affected by any other lesions. And in a short axis view, go to the papillary muscle. From there, again, move the transducer towards mitral wall, keeping your one finger on a stop button, and then you get the area and you measure it. The limit is now you see here. So you see when you are here, you see this is the shortest area you see here, and then you freeze it and measure it. The limitations are in about 5% of the cases there are suboptimal imaging. Say every time you cannot get an imaging like this because you have to measure this area. Sometimes there is obesity, atrial fibrillation, emphysema, and many other situations where you cannot get a good imaging, so you cannot adequately get a mitral wall area. In atrial fibrillation, the walls are moving irregularly. Sometimes you may find it 1.2, sometimes you will find it 1, sometimes you will find it 1.3. So take several measurements and take an average of them. Lack of technical expertise. So what I always tell to our candidate that even in a normal patient, try to calculate a mitral wall area. Say that is only then, because when you really want to calculate it, you will not be able to get it also. So always measure it in a. Now this thing, what I wanted to tell you, instrument setting, for example, I say, if your gain is very high, it will encroach on the mitral wall area. So your area will be reduced. If your gain is very low, it will go away and your mitral wall area will be elongated more or so. So gain should be very adequate, neither should be too high and neither should be too low. That is written as instrument settings or so. So, but these three, what you found over time, you will automatically be expert in a instrument setting. But these things you have to keep in mind also. Now, there are certain, now next after, because you have got some idea by 2D echo, then you have got by 2D planimetry. Sometimes you may not get an idea by a planimetry. Then a wall area can be determined by what is known as a pressure half time. Now, this is a slightly difficult physics. Don't try to cram it up, because theoretically it is a time interval in milliseconds required by the pressure gradient to fall to its initial value. So now, so how much time it takes for the pressure gradient to decline by half from a peak value? So when there is stenotic orifice, that means there is a large left atrial pressure as compared to LV pressure. When the pressure is very large in LA, it takes a longer time to empty into the left ventricle, causing a prolongation. Forget about it. Remember, machine automatically connects for you. The formula is 220 divided by pressure half time, and you automatically get a mitral valve area. So you, rather than getting all this, best is to it is a popular method because of simplicity and reproducibility, but it has certain limitations. And this is how it takes. For example, here we have shown you, you take a pressure half time, 220 by pressure half time, and you get a mitral valve area. So our duty is to get a good mitral valve area. Now see, this is a Doppler. This is D, only trace the deceleration slope and the machine automatically give you the area. You see it is 220 by pressure half time. Auto view this see. You got a slope of 174 and the pressure half time automatically comes to 1.2 centimeters. 220 by pressure half time. The pressure half time is 182 milliseconds. So 220 by pressure half time is a 1.21 area. Your job is to get a good mitral Doppler tracing, and then you take it from here to here, and this is the A wave. You don't have to go there. This is the deceleration slope, and you measure from the E wave to the base, and here you get it automatically gives you a pressure half time. So that is a very important thing also, and nothing much is required. We'll show you again many times also.
Sir, voice is very much breaking.
This is a mitral Doppler. भैया कहाँ तक मैं लाऊं अपनी voice? So can you see this? So this is how we get a mitral valve area by a pressure half time. Now there are certain limitations of pressure half time. I will only tell you those limitations which you encounter in a day-to-day practice. Now you see, for a calculation of the mitral valve area, you require is this slope. Unless you don't get this slope, you'll not get a mitral valve area because you have to trace this slope, is here. Now, when there is a tachycardia, you don't know where do you put a slope, because it's a tachycardia with the heart rate significant increase. Now you see, you cannot get a slope like this, so you cannot calculate the mitral valve area. Now here, what we do, you cannot ask the patient to sit there for 1 hour, 2 hours, and ask him to remain calm and quiet and all this. So what we normally do, because neither the patient can wait, neither we can wait, we ask them to take a small 25 milligrams of beta blocker in the night, a short-acting one, and then take another 25 milligrams 2 hours before they come to the lab. So by this time, their heart rate gets settled down. So you call them at a time when you are already doing an echo by giving them 25 milligrams of beta log in the night, and 2 hours before they come to the lab, and if they're very anxious, give them some sedative or so. And the effect of these two will be that you suddenly get a good slope. So from here, where you cannot get any EF slope also because of tachycardia, here you get a slope, and you see when you measure it, the pressure of time is 121 milliseconds, and 220 by 1 milliseconds give you the mitral valve area. So the sinus tachycardia will find an important problem, and either you can wait for some time or give the patient some beta blocker. So this is a very common problem you will face. The second problem very commonly you will face is an atrial fibrillation. Many of these patients come with an atrial fibrillation. And in an atrial fibrillation, there are very chaotic complexes. Some are small, some are rapid, some are other. What we do in these, you see, you cannot measure here, you cannot measure here, you cannot measure here, you cannot measure here. So when we do what we do, we go on recording the mitral Doppler. So we have put a cursor here. We go on recording the mitral area, mitral wall. A time will come when suddenly there is a large diastolic slope. You will not get like this always. So by keeping this a continuous recording, you will get a one complex which is wide, and here you can see a nice slope. And you see here we measured it. It is 428 milliseconds, and 220 by 428 is 0.5 centimeters square. So these are the two important problems which you will face. Is it clear to all of you or not yet?
Yes,
We'll
sir.
make it. So only thing is that yes, reduce the heart rate and go on recording. You see any atrial fibrillation case you do, when you go on recording, some complexes are bound to come which have got a wide diastolic slope, and you can measure this complex and get a mitral wall area. Third is again you will find non-linear mitral deceleration slope. Now you see this is a normal mitral wall slope. Now here you see this non-linear. Now if you measure here, you may get an area of almost about 2 to 3 centimeters or so. So we do not measure here. We measure the mid-diastolic slope like this. So because this is known as a non-linear slope. So here you see suddenly it dips like this and then slows down. So here you see, just to show what we have done, we have tried to measure here, and the area comes about 2.4 centimeters square. In the same patient, again you see, we have measured from here. We have ignored the middle portion. We have measured from here time on 92. 220 by 92 is 2.4. Same patient now see here. What we have done, we have 4 centimeters square. So you see this, we have this portion, we have taken a mid-diastolic slope, and from the mid-diastolic slope, you come here. You don't go like this again, but you say from 2 to 2.4 as a bimodal diastolic slope. So never measure from the initial downward slope unless it is a smooth curve, but always measure from the mid portion, and then you get a correct mitral wall area. Now, this again you will get a important one. This is one of the last limitation. This is the LV, this is the aorta, this is the aortic wall aorta, and you see the patient has got a significant aortic regurgitation and an aortic stenosis. Now you see what happens. This is now issue. What happens in aortic re now? What is this now? 220 by pressure half time is the mitral wall area. If suppose this comes here, so the pressure of time will be reduced, because instead of coming to this, it's only coming out this. So the mitral wall area will increase. So because I told you how much time it takes for the LA and LV pressure to almost equalize. So if the pressure of time comes up to this place, let us say. So if you measure by a pressure half time, you'll get a high area. To show you this thing and why it happens is now when in aortic regurgitation, the LV fills up from two sources. One is from the mitral, from the left atrium, that is in diastole. The aortic regurgitation is in diastole. So the aortic regurgitation occurs in diastole. So because of the two sources, the LV diastolic pressure increases. So when its diastolic pressure increases, so this line will come up to this place. So your pressure after will be reduced and your area will increase which is by default. So in those situations, don't use a pressure half time, but use a 2D planimetered area. As I told you, the 2D planimetered area is not affected by any hemodynamic feature. This is because of an increase in the LV pressure. bringing the pressure half time here and this and reducing it. So we can correct it by taking the area. Now remember one thing, sometimes when a patient undergoes the mitral valvotomy, for the first 48 to 72 hours, don't depend on pressure half time, but depend on the mitral valve area. Now, many of these things are not known to intervention cardiologists. Suppose they have done a mitral valvotomy in the morning. They will send you a case, the same case in the evening. Please let us know about the gradients also. So in that case, don't determine the gradients, but only with the mitral valve area, it should increase by almost 50% or so. So that is just to tell you that don't decrease it also. Elderly patient, don't worry, when the aortic stenosis will be taught and it will be there. So the most common you will get is sinus tachycardia, atrial fibrillation, non-linear slope, moderately severe MR, and mild MR, mild AR will not affect the moderately severe, immediate post-balloon mitral valvotomy, and then some other these things are other. For example, pregnancy, there is high output state. When there is high output state, the peak gradient, as I told you, depends upon the blood going through an orifice. So that they become a artificial increased gradients. So now, what are the criteria for severity? In pre-2014, it was mainly based on some area and the mean gradient. For example, in the valve area, they said it is more than 1.5, it is mild. If it is 1 to 1.5, it is moderate. And it is less than 1, it is severe. This was before 2014. And other supportive findings, as if this was there, as I told you earlier, as the valve area decreases, the mean gradient increases. So here it becomes 10, and the pulmonary artery pressure. So according to them, they found that this was the criteria more than 1.5, 1 to 1.5 and less than 1. So in 2014, there was an ACC AHA criteria. They redefined it, and they found that when the mitral valve area is less than 1.5 centimeters square with a pressure after more than 150, it indicates a severe. So that means according to them, this becomes a severe one, not a moderate. And very severe is when it is less than 1. So what I said, now 220 divided by 220 is 1. So what I suggest, what you can do, you can go to the Google or somewhere and just click on ACC AHA criteria on valvular heart disease. Everything will come in front of you. So here you see, nowhere they have given an importance to the mean gradient. Nowhere. Nowhere they have given importance to the mean gradient, but they only concentrated on the area. But we also think about a pulmonary artery pressure as one of the criteria. So, but this is just to show that as the area decreases, the gradient decreases. So this is the new criteria of what we do. Say many of the persons are not aware of this. Now suppose the area is 1.3 centimeters square. So what we write in our report, severe bracket में ACC-AHA criteria 2014 mitral stenosis. Well, otherwise tomorrow they will think that since when the 1.3 centimeters have started becoming severe, it was always a moderate. So always you write in a bracket ACC-AHA criteria. So this was a very good paper on valvular heart disease, and we have reduced it so you can always read it and read it your whatever connects you, not that you have to read whole of the paper, and it is easily available anywhere. So this is the new terminology which has come in the ACC-AHA criteria. And sometimes there's a left atrial myxoma, when it goes across the mitral valve, produces an obstruction, can give you a sign of a mitral stenosis. For example, here you see whenever a patient of mitral stenosis complains of syncope, giddiness, we think always try to rule out. So this is a left ventricle, left atrium. This is the interatrial septum, and there is a mass during diastole goes across the mitral valve into the LV and can produce an obstruction. And this is called triatriatum. You need not worry. There is plenty of time for you. This is LV, this is LA, and this is the mitral valve, and this is the membrane into the left atrium. So there is a narrowing stenosis both at the wall level and at the level of the membrane, which is known as the called triatriatum. And this can also mimic a mitral stenosis. So these are some of the mimickers of a mitral stenosis. You can see a nice membrane into the left atrium, and if you don't see it, then you miss the diagnosis of this one also. Again, the 2D echo will be very helpful in seeing this. So these are one of the two conditions also. Now again, mean gradient, you see, again I told you, you have always to take a view where you are completely parallel to the flow. Now you see, this is the apical view, left ventricle, left atrium, sorry, right atrium, left atrium, a significant enlargement of the left atrium. There is a turbulence across the mitral wall, and you put a CW Doppler, and you get a good this, and you can see here. When you trace it, you'll get a mean gradient, and here you see that this measuring this slope will give you the mitral wall area. When you planimeter it, it will give you, now some planimetry has been done here, and it gives you everything also. But if you have to find the pressure of time, trace this. Now you see, always measure 3. A pressure of time here will be different, here will be different, here may be different. So gain should be reduced, and you can measure pressure of time to get a mitral wall area. Otherwise, you can get a mean and a peak gradient by planimetering or so. But you see, just as a practice, you can do it. So this may be difficult. It is not difficult. We take an apical view, obtain maximum velocity. How? By taking a Doppler across the mitral wall, obtain a mean gradient in T-way. How? By planimetering the area, determine mitral wall area by PST. How? By the EF slope, and then determine a PA pressure. How? By getting a TR This, of course, we don't do so much. We don't tell you. So these are only by a good apical view you can get a good apical view and a CW Doppler. You can get everything you require from a mitral wall Doppler. Steps 4 or so, you can get everything. The complications. So what we have written as complications could be the effect of mitral stenosis, but you have to see them. For example, this. Now, this is the right ventricle, left ventricle, mitral wall, left atrium. You see a marked smoke moving. This smoke is known as a spontaneous contrast echo. Then you see the patient is in atrial fibrillation. So because of the low flow state, many of these blood components get opacified by the ultrasonic beaming, and you see this. Whenever you see a spontaneous contrast echo, always look for an atrial thrombus, because they are a precursor for the development of thrombus. It is very uncommon to see a thrombus without a spontaneous contrast echo. And if you see a thrombus, don't see a thrombus, follow these are patients, because 10 to 15% of them can develop a thrombus over a period of time. So this is a beautiful example of a smoke into the left atrium. This is like a smoke, somebody calls it spontaneous contrast echo. And you see a typical doming of the anterior mitral leaflet, thickening, and the posterior motion, anterior motion of the posterior leaflet. And sometimes you can get a multiple clots. To see a spontaneous contrast echo, there is a transesophageal, a multiple contrast echo, a spontaneous contrast echo, and multiple clots. So these can convert into multiple clots, and you can see the presence of these things with a spontaneous contrast echo. Here you can see also in various ways a contrast echo. Same thing. And this is when you practice, this is known as the left atrial appendage. It is an extension of the left ventricle, left atrium. It is a finger-like projection of the left atrium, especially when we get a case of atrial fibrillation. And how we get it again will depend upon when the live demonstration is done. But what I do, and remember, here you don't see a pulmonary artery. In a short axis view, you see the RA, RV, aorta, and a pulmonary artery. When you rotate the transducer in such a way that the pulmonary artery disappears, then you get this appendage. Now, a thrombus may be there, but it may not be seen on a transthoracic echo, but may be seen on a transesophageal echo. So this is how you see. But sometimes you can try to see it if you want to. In these cases also, you see this is the finger-like projection, and this is the left atrium. So just go on by practicing, and you will very easily get it. And you see there is no clot into the left, because normally transesophageal echo is the most important uh, technique to see this. And this, as compared to this, you see this is another patient. You see this is left iliac appendage, and you see there is a large clots into the left atrial appendage. As compared to this, you see there was a clean left atrial appendage, but here you see a clot present into the left atrial appendage. You see this. So it is by good practice that you can see it. Whether you are able to see it or not, it is not essential, but at least attempts should be made to see it. And you see again a small mobile left atrial appendage clot. You see, this is the LA, and you see the small mobile LA clot in the left atrial appendage. So it is worthwhile to, at least in short axis view, whenever you do any study, always try to see for a mitral valve area and a left atrial appendage, even in a normal person. That is my teaching to you at this stages. Again, you see a ball wall thrombus. You see a large spontaneous contrast echo, and this large clot comes so these patients cannot be operated till they are there, and you see a nice spontaneous contrast echo. So these are some of the examples of this. So you see here, this patient has got a mitral stenosis. Why? With a doming of the anterior mitral leaflet, with a convexity toward the left ventricle. There is a paradoxical motion of the posterior cusp toward the anterior one, and you see there is a left or right atrial shunt. This is a modified view. Left atrium, right atrium. This is a modified view. You can see a contrast. So this is what is known as you yourself let me know just now. So a combination of mitral stenosis to ASD known as a Lutembacher syndrome. So Lutembacher syndrome can be a congenital or an acquired ASD. Acquired ASD means that somebody has done a balloon dilatation where they have punctured this left atrium and this septum, and this has become a large ASD and will matter. This is known as a Lutembacher syndrome, a combination of the mitral stenosis and the ASD, or the left to right. So any type of ASD and a mitral stenosis combination can lead to what is known as the Lutembacher syndrome. Then once you have finished all your tests, you see this is known as a Wilkinson score. A Wilkinson score on a mitral valve depends upon the mobility. You give 1 point each. Mobility, thickening. As the thickening goes on increasing, you can go to 1 score, 2 score, 3 score, 4 score. Caudal involvement and calcification. You see calcification of the cusp and mobility. So you give to, depending upon this, you can go on giving 1 point to each. Its importance came long time back when they felt that anything more than 8 scores does not lead to a good balloon dilatation. But no, we can now go up to 8, 10, like this also intervention cardiology can go up to 10 to 11 and perform. But you see, the limitation is that in this Wilkins score, they have not included commissions. And commissions are a very important thing to decide about the balloon dilatation. The commissions are fused, calcified, so they have not given it. So as the mobility decreases, the point increases. As the thickening increases, point decreases. Normal thickening is about 4 millimeters or so. Remember, any thickening of the valve is more is ideal in a sort of fundamental imaging rather than the other imaging. Calcification, the same thing happens also. So there are various types of scores have been given, but this is the age-old Wilkins score. Now see again the commissure. You always have to define a commissure. This commissure is fused, one commissure is open, one commissure is open, both commissures are open. If this is like this, the patient does not, this indicates either the patient has undergone a mitral valvotomy or he is not fit to undergo mitral valvotomy because the commissures are already split. So what they can do further? These are the ideal cases to develop have a balloon dilatation. So we always mention so that when you measure the area, you go from here, you go here, go up to the commissures and then come here like this. Here you are only going, here the commissures are fused, only going up to this area. But here you can cover the commissure to get the areas. Always important to define it. And for example, here you see there is nothing, and here you see there is a calcified commissures. So this is marked calcification, and because they have to split the commissures, so we always write that the commissures are calcified, and here they are not calcified, and so that means this does not become fit for a balloon valvotomy. So one word, last word about stress echo. We do a lot of stress echo in cases of mitral stenosis also. Why? When there is a mismatch between clinical symptoms and hemodynamics. For example, a patient may having a symptoms of breathlessness or anything, but his resting steady is virtually okay. His mitral wall area may be less, his or her gradient may be less. So then the question appears, are the symptoms due to severe stenosis or it is because of COPD, obesity, poor conditioning to exercise? So we have to explain the symptoms, like why the patient is symptomatic. So and because the other studies are done into a resting phase, so here we can do it slightly in a exercise phase. So what we do, we calculate the resting mean gradient and PA pressure, not the area. We give the patient exercise on a treadmill, or the patient doesn't exercise on the echo bed also, till the symptoms occurs, or about 70% of the target heart rate achieved. Repeat after exercise. Now, what happens? Once you exercise a patient, his heart rate increases. When the heart rate increases, the left atrial pressure increases. When the left atrial pressure increases because of the shortening of the diastole, when there is a tachycardia, the diastole gets shortened. When the diastole gets shortened, the LA pressure increases, so there will be increase in the mean gradient. And when the mean gradient increases, the same increased LA pressure is transmitted back to the pulmonary circulation and the PA pressure is increased. So this is the basic of this. So in mitral valve, significant MS with no symptoms. Why? Non-significant MS with symptoms, moderate MS or no symptoms but prior to non-cardiac surgery or pregnancy. And when main thing is when there is a discrepancy between the symptoms and the resting echo, then we do this. Now, for example, here you see when you do it, how do you interpret it? You see symptoms. The mean gradient should increase by more than 15 millimeters on exercise or 18 meters during the dobutamine, but we normally use exercise, not dobutamine. So if you have done a resting study, when the patient is exercise, if he's very much symptomatic, that is the thing. And the pulmonary artery pressure usually goes more than 55 to 60. So mainly we see mean gradients and the PA pressure. For example, here you see the mean gradient is 6 and the TR gradient is only 32. And you see, this is the mitral Doppler. It has been traced, which gives rise to the mean gradient of about 6, you can see, and the mitral area of 1.4. So by planimetering it, you are getting the whole thing. And by this pressure half time, you are getting an area. So the mean is 6 millimeters mercury, and the TR gradient is hardly about 32. So when the patient exercises, from 6 it becomes 18. So there was a significant dyspnea. The mean gradient has become 18, must have significantly increased. And the TR gradients from 32 becomes 53, at LA pressure, at IVC pressure, it comes about 60. So that means we can say that this patient's symptoms of dyspnea are because of associated mitral stenosis. Now, what happens? Remember, once you have exercised the patient, what happens that the heart rate increases. When the heart rate increases, then what happens that you cannot see the various slopes, you cannot do anything. So what we do, we go on recording, or the first half of minute or 1 minute, we see for any wall motion abnormality, whether there is any wall motion abnormality or not. And after 1 minute or so, when the heart rate slightly settles down, then you can see the slope. So that is how we continue it, or we go on recording and then measure later on. But in an elderly individuals, we also see for a wall motion abnormality. So the increase in the mean gradient and increase in the PA pressure. Now, when we say the whether when you write a report, write in such a way that is the wall amenability to balloon metal, why? Whether it is they are fused, split, or calcified. Degree of MR, a mild is all right, but a moderate or more is usually unamenability to BMB, subvalvular apparatus, and concomitant severe other valvular heart disease. If the patient has got mitral stenosis with aortic stenosis, then you cannot just tackle one valve and leave the other valve also. Then you have to undergo surgery, because by this you can only calculate really one valve but not the other one. Suppose the patient has mitral valve with stenosis with aortic regurgitation, you have to relieve the aortic regurgitation of valve replacement. But generally, what we do, we write this thing, and degree of MR and LA clot, and if there is any other valve lesion present. And in our Indian summary of BME, it is Indians are not everywhere a moderate or a severe stenosis, symptomatic thrombus, less than moderate MR, no calcification of commisure, PA pressure of more than 60, and high saturation. That will come later also. So so finally approach the patient of mitral is to start with a parasternal long axis view. Firstly, see that the patient is in atrial fibrillation. In parasternal long axis view, you see for about 2-3 things. Number two, the degree of thickening of the mitral cusp. Sometimes the distance between the separation index, because the lesser it is, the more severe. Number three, you see for a left atrial, and then really see for any thrombus. So this is what you see. Besides seeing the, of course, you have to see all the things. You have to see the cardiac effusion, RV size, and all other things also. But coming to the mitral stenosis part, you see that here you can see that the doming of the leaflet, there is no significant calcification except the tip of the leaflets here, and there is a spontaneous content, and here you see that this is known as a separation index. You take this, you see between anterior and posterior 0.5, which indicates a severe one. More than 10 to 12 indicates a mild. And here, just for demonstration's sake, we have put an M mode on the LA to show how a spontaneous contrast echo looks like. So these are the 3-4 things you see: a thickening of the leaflet or calcification, doming of the cusp, the difference between the two cusps, the left atrial, this contrast echo, and any thrombus. Then you go to the short access view. In short access view, we see for wall area. That is one. Number two, we see for any calcification of the commissures. Here you see both the commissures are calcified, and then you see a left atrial appendage. So you have seen three things in parasternal long axis view, three things here besides of course spontaneous contrast echo, and you see a left atrial appendage thrombus. You saw the commissures which are present. You see here
Sir, voice is breaking very much, sir.
area is about 0.5 centimeters square, and this was luckily the same. Eh? And the same thing was seen from a pressure of time, almost same. Then, of course, a apical view, you see the same things again. A thrombus may be seen here. Then you see for the peak gradients, mean gradients, you see a pulmonary artery hypertension and the IVC. So these are all the things you see. So what you have done, you have seen all the walls, and you have seen that there is even no it is isolated mitral wall lesion, and no other walls are involved. You see for a pulmonary artery hypertension and the various areas. A mean PA pressure 0.6 into the peak PA pressure plus 2 gives you a mean PA pressure. If you had that, we have already told you or so. So how do you report a mitral stenosis?
So you are not audible. Voice is
Anatomical appearance of the wall. Calcific, non-calcific. Oh, भाई void का तो अब तो खत्म ही हो रहा है तो void तो can you hear? Because the interconnect connection they say stable also. But you must be having these lectures with you. Can you hear now? The appearance of the wall, severity of the stenosis, any anatomical complication, MR present or not at this severity, degree of pulmonary hypertension, any other valve involvement, giving an idea of LV and RV function, and commissures and amenability to valve value and value plastic. So that what we have told earlier, the same mentioned in the final report, that these are the, so that the person who has sent you this can get a fairly good idea as to what is the status of the valve, whether patient should go for a balloon dilatation or patient should go for surgery. One word about tricuspid stenosis. Their common causes are a rheumatic heart disease, which we have done, a tumor vegetation, a repeated catheterization and pacemaker leads in with this. The normal velocity is 0.5 to 1 meter per second, and the normal area is 7 to 9 centimeters square, and mean gradient less than 2. All right-sided velocities have to be measured in end expiration. During inspiration, there is more flow into the right ventricle. So all the velocity, you will always get a very stable report, is stable Doppler readings when you measure in end expiration, because respiration always alters the way the various velocities are so. The severe TS is when the mean grade is more than 5 to 10, PHT more than 190, area less than 1 centimeter square, and RA large, IVC large, and all these things. So you can see here, this patient, left ventricle, right ventricle, RA, LA. You can see RA is also significantly large. Why? Because there is a tricuspid stenosis. So the increased pressure has to be there on the RA, like an LA. LA is enlarged because it has to push the blood through a narrow mitral orifice. RA is enlarged because it has to push the blood through a narrow mitral orifice. So you can see there is a thickening of the tricuspid leaflets, and there is a restricted opening. Normally they would have opened fully here. So they are open there, and you see again there is a turbulence across the tricuspid wall and a TR. TR indicative of a disease wall or a pulmonary hypertension. And you see there is a modified view, and we have taken this, and the you can see the mean gradient is about 7.55. The area is I'll show you in the next one also. So that means it forms a severe one also, because we have again traced it. Why it is written MB? Because in certain equipment they have not given a facility only for the tricuspid valve planimetry. So we used to we used to go to the mitral valve and then planimeter it also. So you can see the mean grade is 5, and you see the pressure of time is about 90, and the area is about 0.90. The pressure of time is 243, so indicating a severe tricuspid stenosis. Always report for tricuspid. Unfortunately, we lost follow-up of this patient. We are still not giving a diagnosis. You see, the isolated tricuspid stenosis is very difficult to get. It has to be associated with mitral valve. So you see, this is right ventricle, right atrium, and you see there's a thickening of the tricuspid valve with a doming. You can this is zoom the view with a doming. So and you see there is a turbulence, and again you see the TR and the tricuspid stenosis. Unfortunately, we lost the follow-up of this. So uh, so the take-home message is a good clinical examination as a guide. Ideally, heart rate should be below 100. I have seen when it is more than 100, it just gives a sort of a C. And so if the heart rate is increased, try to postpone it for 1 day or maybe like this, or give a small dose of beta blocker. And all I never limit to these. All ideal views. Now, for example, if it is a PA pressure, you have to include RV inflow view also, subcostal also. But these are some of the standard views which will give you all the information. Real test of practice is a 2D MView, and commissioners use multiple parameters to assess the severity. Don't go on one. And one thing also, see all valves, give a complete report, mention limitations. Don't worry or say that you cannot do it. Sometimes you write that by 2D echo, we could not get a correct MV orifice area, or because of atrial fibrillation, we could not get. Whatever, they never forced to give a 100% diagnosis, but always say that what is missing also. So now, any questions from your side?
Good evening, sir. Rakesh is over here.
Anji, aa jao bhai. हाँ.
So,
Hello, Dr. Prasenjit here, sir. Just can I have that slide with which can differentiate between a rheumatic mitral valve and calcified age-related mitral valve, sir?
There are various criteria in the literature on this. See this one. These are usually an elderly individuals. Number one. And I got a complete. There are various criteria to differentiate between rheumatic also. Now these patients will not have a commissure fusion also, because it is not a rheumatic disease; it's a degenerative disease. Number two, the domain may not be there, and you can see this is elderly individual. Number one, a commissures may not be fused, a dense mitral annular calcification, and and here you see a turbulence across it. You can see a turbulence across it, and you see, and then you take a mean and the gradients also. So number one, if the same patient would have been about 16 years, 20 years or so. So number one, a unilateral univalvular involvement rather than multivalvular involvement, a univalvular involvement rather than multivalvular involvement. Now these patients can have associated mild aortic stenosis, but usually if there is no, it is single valve involvement. A multi-valve involvement usually indicates the presence of a rheumatic etiology. Number two, there is no commissural fusion. Number three, there is a gross mitral annular calcification, and then you can see an increased peak and mean gradients also. In the rheumatic, I told you that the commissures are fused and other features are there. And there are nice literature points also which I don't want to confuse you. There are various papers of differentiation between this and calcified.